Welcome to the Pancreatic Cancer Action Network's webinar, Pancreatic Neuroendocrine Tumors. My name is Sheila Bott, and I'm the Manager of Scientific and Medical Affairs for the organization. At the Pancreatic Cancer Action Network, our goal is to give you hope through better resources so you can make informed decisions. Patient Central can provide free, personalized information on many topics, including pancreatic cancer specialists and treatment options. Contact Patient Central at 877-2-PanCAN or email patientcentral@pancan.org. I would also like to take this opportunity to thank our webinar sponsor, Ispen, and to thank our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ispen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by questions, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. We encourage specific questions to be addressed by your healthcare provider. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Eric Liu is a surgeon specializing in diagnosing and treating neuroendocrine tumors at the Rocky Mountain Cancer Centers in Denver, Colorado. He is the co-director of surgical services at the Neuroendocrine Institute there. Dr. Liu was responsible for establishing the first clinical trial of the gallium-68 PET scan to diagnose neuroendocrine tumors in the United States while at Vanderbilt. Dr. Liu, I will turn the presentation over to you.
So we are going to talk today about pancreatic neuroendocrine tumors, which are a little bit different than what PanCAN normally does. And let me just explain. Okay, so let me just start by saying pancreatic neuroendocrine tumors and pancreatic neuroendocrine cancer is not, let's make this clear, the regular kind of pancreas cancer you think of and hear about all the time. It is not that usual pancreas cancer. It is not that super deadly pancreas cancer. In other words, it is not adenocarcinoma of the pancreas. And I say that because they can be so easily mixed up. You hear about people who die of pancreas cancer. Well, what does that really mean? Well, if it's you, it makes a big difference because your treatments will be different, the people you see will be different, the way you think about it will be different, how long you'll live will be different. So those are all important things, obviously. And maybe the most important thing you got to understand, so this is a little clip of the PanCAN website. And you can see all this information on here is related to pancreatic adenocarcinoma. Most importantly, it is all purple. Okay, so you will have to change your wardrobe relative to the type of disease that you have. Neuroendocrine is a little bit different. Neuroendocrine is kind of a zebra disease, kind of an unusual, rare zebra disease. So if you like purple stripes, zebra stripes, then that's the way to go. Okay, so zebra stripes. So those are some important things. The information you'd have to sift through to make sure they're different. And PanCAN, of course, has a lot of people who talk about neuroendocrine, but sometimes the information can get so confusing, you want to make sure you separate the two. And sometimes going to other like neuroendocrine resources can help you clarify these things. So just understand this is very hypercritically important. And I say that because I've had many patients who were diagnosed with adenocarcinoma, and it turned out they had neuroendocrine. And I was just telling Sheila a second ago, my grandmother also died of pancreatic adenocarcinoma. So it really strikes. I understand this disease from a different perspective as well, too, not just as a physician. So they're doing great, great work. But for those with neuroendocrine, just understand they're two completely different diseases. So I'll explain in a second. All right. Well, why does that make a difference? Well, look at these two people here, right? If anyone who walks around with an iPhone, which is probably all of you, can thank Mr. Steve Jobs, who unfortunately did die of pancreatic neuroendocrine. And if you look at Aretha Franklin, you can see, too, she died of neuroendocrine. But look at what the title says. Let me see if I can make this work. What is that? Okay, and that is a very important question, and that's what I hope to address today. Okay, so what are neuroendocrine tumors? Let's go back and make sure people understand kind of what this is. What are pancreatic neuroendocrine tumors? They're a little bit different. And then people ask, well, it says tumor. Is it really a cancer? We'll talk about that. How do we diagnose it? How do we treat it, of course? And of course, we want to talk about some of the exciting things that are happening in research. But I kind of want to tell you a little bit about my philosophy of it as a neuroendocrine treater, as someone who takes care of people with neuroendocrine, because it's so very different. And really there's an important element to just the philosophy and the approach to it, because it's a different type of disease. So hopefully these will all be important things. And I'll try not to inundate you with a bunch of graphs and numbers and charts and things like that. That's what we would normally talk about with the physicians and the other professionals. But for you, I hope you just kind of walk away understanding the disease a little bit better, and how you, as perhaps a patient or a caregiver, should maybe think about how you can approach the disease yourself, okay? I hope that helps. All right. So let's get started. So what are neuroendocrine tumors? Let's talk about that. Well, it turns out that you have a bunch of what are called neuroendocrine cells through your body. I don't know if you know this, but breathing and eating are phenomenally complicated procedures, right? I live in Denver, so the air is thin. Some of you probably live in Miami, where the food is really, really good. So those things are complicated. If you had to think about moving air or food through your gut, you would probably be terrible at it. So what happens is your body has these teeny tiny little cells scattered throughout your what's called aerodigestive tract, all the way from your mouth down to your bottom. And they work by secreting teeny tiny little hormones, right? And these cells work in the background, so you don't have to think about how much water to secrete into your gut, how much to absorb, how much sugar to control, things like that. And they do it, they're smart, so they're neuro, like smart, and endocrine because they function through hormones, okay? And you can see here on this graph right here, these are probably 7 of the most famous hormones that are produced in your gut and your bowels and lungs. But this is probably 7 of 7,000. It's a little hubris to think we have any clue as to really what's going on. It's so complicated. So that's what we do. But the interesting thing is they also express something called a somatostatin receptor. You don't need to know the details of that. But basically, this is a hormone that we use a lot for the treatment and understanding of the disease. Okay? So it's a complicated process. And so there are a lot of it, right? So the definitions are important because you may hear a lot of words like neuroendocrine tumors, cancer, carcinoid. Well, it's complicated, right? So the wording comes because we didn't have a good word for the disease until about almost 20 years ago. So that meant for 120 years we had terrible terminology for it. So we say neuroendocrine tumors are these small, generally slow-growing tumors that come anywhere from the lungs or the digestive tract or some other spots. You may have heard of an old term called a carcinoid tumor. We don't talk about it for the pancreas, but a carcinoid tumor is a kind of a cousin disease in which the neuroendocrine tumors come from a tube, so a breathing tube or a digestive tube, so like a small intestinal neuroendocrine tumor, a lung neuroendocrine tumor. Those are sometimes called carcinoids in the old term. So if you hear them, that's kind of how it works. Now, for us, you can see there are actually a bunch of different neuroendocrine tumors, right? Today we're going to talk mostly about this, right? But this barely even scratches the surface of what the disease is. And these are all these other neuroendocrine tumors. And so those are, if you want to check out some other resources for neuroendocrine, just understand that they come from different places. But what you can just begin to see probably is that it's a phenomenally complicated disease. It comes from different places. It causes all different kinds of symptoms. And so there's a lot to figure out and understand. And that, unfortunately, there's a lot of confusion, right, even among the healthcare providers and the healthcare professionals. So unfortunately, it's something, why we're doing this webinar right now, so you guys can be educated and understand exactly what it is that we're doing and what we're trying to do to make your lives better, okay? So that's the complicated part of neuroendocrine. But let's go to pancreas specifically, all right? So just one understanding. So the pancreas is this magical, brilliant organ that sits right in the middle and kind of towards your back of your belly. But it's actually 2 organs in one, okay? So thanks, guys. I stole this picture off your website. But that's the pancreas right there, this yellow banana-shaped organ, okay? And it does 2 things. One, okay, it helps secrete digestive juices. So for those of you who are eating your pizza and hamburger right now, you can thank your pancreas for allowing you to absorb all that delicious stuff. So that just helps. And 99% of the pancreas is devoted to making juice, right, digestive juice. But 1% of it, this teeny tiny little amount, is used to control blood sugars, appetite, and probably more magical things with hormones. So the one over here is called the exocrine, And the one over here is called endocrine. So X means out and endo means in. So this is all the juice that goes out into your gut, and this is all the juice that goes into your body. Does that make sense? Now these are very, very different. Why? Because the one that comes from the exocrine is the adenocarcinoma, right? This is the challenging, difficult, very, very deadly kind of disease. Whereas the neuroendocrine comes from this part, and it behaves quite differently. So we want to make sure that we separate those two and understand it. It's because the pancreas is two organs in one. Okay? So the question is, well, you keep calling it a tumor. I hear it's cancer. I mean, what exactly is it? Well, it is a cancer. Okay? Yes, it is, but not always. So neuroendocrine, just by the way it is really a spectrum of diseases. It's probably like 75 different types. And you can have some that are really quite slow and they can take a long time to grow. And there are some, honestly, that are just as angry as the adenocarcinoma. And those can be very challenging as well. So this is why it can be so confusing sometimes. People say, oh, neuroendocrine, that's nothing. Where some people will die of it in 12 to 18 months. And so there's a lot to think about when you begin to understand the diseases. So really, you should think of it like this, right? This is kind of how neuroendocrine is. There was a day when I was a boy when Baskin-Robbins only had 31 flavors, and I thought that was manageable. Now there are like 75 different flavors. Neuroendocrine is very similar, okay? It's like 75 different flavors of neuroendocrine. And so there aren't that many people that see it on a day-to-day basis and understand the lung part, the pancreas part, the liver part, the bowel part, the rectum part. So if you want to be a master of all the different flavors of neuroendocrine, just like the master of Baskin-Robbins, the one thing, if you can leave with any piece of information, is I think you should really work with a neuroendocrine specialist, because he or she can help you understand and guide you through the nuances of the disease. And there are a lot of nuances, which is a good thing, but there are a lot. And so how do we help you live better? How do we have you live longer? Those are the things we want to accomplish and achieve, right? Now, it's important because it turns out that there's a lot more neuroendocrine than we thought, and the rate is going up. So if you look at this beautiful graph that was made by Dr. Desari, what he found when he studied the rates of neuroendocrine is that it has been going up for sure over the past 40 years. So you can see here, if you look at lung, this is the one that's been going up the most. Small intestine, that's been going up a lot too. Rectum, we've been screening a lot. Those rates are definitely going up in the past 20 years. But if you look at pancreas too, pancreas has been going up as well. So we do have to keep our eye on the ball because there are more people with this disease. And luckily, there are more people who are living with the disease too. Okay? So how do we diagnose it? So how do we figure this out? Well, that's not so easy. There can be a delay of diagnosis. I mean, it's quoted between 5 to 9 years, but usually it runs between 2 or 3 years, which just means that people can have a lot of symptoms and not know they have disease. Why? Because the symptoms are very, very generic. Lots and lots of people can have symptoms. I'm sure all of you who are logged on right now, and some of you who just had that pizza may be having some of these symptoms, right? Who has never had a little diarrhea, right? Who has never, women who are in middle age, who hasn't flushed? Who hasn't had abdominal pain? Who hasn't had anger, right? I mean, I'm pretty sure the people who helped me do this website are feeling anger towards me right now for talking too much. So these are very common things that happen. And so they just kind of get overlooked. And it's not until they discover, my goodness, you have this weird zebra disease, that everything starts to make sense. Okay? So it can be a little bit of a challenge symptomatically. But they're real. Problem is, 70% of neuroendocrine patients have no symptoms, and you find them on an incidental scan that's being done for some other reason. Okay, so there's some things to consider. This is why it's so complicated sometimes. Now, you see the symptoms that I've listed here. The reason a lot of people have symptoms is because their tumors secrete hormones, okay, like I had mentioned to you before. So we call those functional tumors. Okay, they secrete one of those well-known tumors I mentioned. So insulin, for example, if you secrete a lot of insulin, your blood sugar will drop. Gastrin, these people are going to have ulcers. Glucagon, they may have diabetes. This very rare VIP, vasoactive intestinal peptide, that can cause terrible diarrhea like cholera. somatostatin, ghrelin. I mean, these are hormones that we don't think about every day. But if your tumor secretes it, it can be torture. It can really hurt. But sometimes these tumors don't secrete really anything that we know of that causes these kinds of classical syndromes. So we call those non-functional, okay? And we can follow them with different kinds of proteins like chromogranin or pancreatic polypeptide or pancreastatin. So you can see here these divides. This is why the different flavors of neuroendocrine are so important to understand, because they affect you differently. You can have a teeny, 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 tiny little tumor that secretes insulin, and that can torture you and can be life-threatening. You can have 50 tumors that secrete nothing but pancreatic polypeptide, and the patient can be completely asymptomatic. So there's quite a variety here, as you can see. Okay. Now, when it comes to kind of figuring out what's going on, there's no question you have to be able to see the disease. All right? That means, for us, imaging, okay? CAT scan, CT scan, MRI, endoscopy and ultrasound, nuclear tests such as Octria scan, or now this new fancy gallium dotatate PET CT. I'll explain to you in 2 seconds what they are. But this imaging is absolutely critical, and I always recommend that people get all of their testing done before they start to make big decisions, because you want to have, pretty obvious, you want to do all your homework before you make a decision, right? Measure twice, cut once. So here, for example, many of you may be aware or have had an endoscopic ultrasound. What does that mean? Well, when they do an endoscopy and they put the camera down your mouth and into your stomach and into your pancreas, they can put a tiny little ultrasound machine right next to it, and they can measure teeny tiny little tumors inside your pancreas. Here's an example here. It's very good. A lot of it's user dependent, but these endoscopists have gotten so good at this now. You can see they found this little 1.5 millimeter tumor. It's a teeny tiny tumor, but that may be enough to secrete hormone to hurt somebody. Okay, but in general, neuroendocrine tumors aren't that hard to find. If you get just one good CT scan, usually you can get a hint of something, right? So here's an example of a CT scan of a patient who was actually asymptomatic, one of my patients, and she had something totally different, and she got a CAT scan. They said, well, you have this issue, but you also have a massive tumor in your pancreas. She's like, what? This is another example, and I just want to this is a little bit different. This is from a small bowel neuroendocrine tumor, but I wanted to show you how beautiful the pictures are. I mean, the technology is so good. You can see these incredibly beautiful pictures of these blood vessels. So we can get a lot of pictures. But to find the tumor itself is actually not that hard. There they are, right there. Okay. So you can get them. Every radiologist should be able to see it and should be worked up and evaluated. Okay. Now here's a little bit of a pearl, just so you know. In general, neuroendocrine tumors don't always show up on CT scan, especially in the liver. And so what we like to do is use the right tests for the right thing. It turns out the MRI of the liver is actually a much, much more sensitive test for picking up tumors. Let me show you a really great example. This was a patient of mine. He had neuroendocrine. His markers were going up. Very, very smart oncologist. Something's going on. As you can see, there's nothing there. That looks like normal liver. But he got an MRI, and there it is there. You see that? So having the right test, you can maybe pick up to 20% more lesions. And this guy just happened, just so you know, we did his operation. He went home in 3 days, and he's been great ever since. So, just having the right information with the right tests with the right providers, super, super important. Okay, so we talked about endoscopy. We talked about ultrasound. We talked about CT scan. We talked about MRI. Let's talk about nuclear. So people think of nuclear as being very scary, but it's a very, very powerful tool for us because it looks at biology, not just kind of pictures, right? So there's an old scan called an Octria scan, which was since 1990, which may not be that far away, but it's essentially completely obsolete now. Okay, but you may have heard about this. There's the more popular FDG PET scan, which is used for kind of our other cancers like regular pancreas adenocarcinoma of the pancreas. That's usually for very angry kind of cancers. We have really specialized tests called carbon-11 HTP or fluorodopa. But the one that's really made a huge difference now is this thing called the gallium scan. Okay, and some of you may have heard this. This, I like to think, has really changed the way that we think about and do neuroendocrine. And let me just tell you why. So when I first started, this was a few years ago. I don't think I'm that old, but it seems like a long time ago. there was a scan called an Octria scan, and these are the pictures you got. You had to come in multiple times. The pictures were very fuzzy. There was a lot of bladder. It's just hard. But when the tests worked out well, you could see kind of these little tumors. And don't get me wrong, this is better than what they had in the 70s, but this is just not that great. So when I first started my career, I was fortunate enough to study in Sweden, where they had really one of the best neuroendocrine clinics in the whole wide world 10 years ago. And when I came back to the United States, I said, hey, we should improve our technology. So we started doing this thing called a gallium-68 dotatate PET-CT. It's now called NetSpot commercially because everyone can have it. But basically what you have is one half of this is something called octreotate, which is a molecule that's like the somatostatin. Remember that receptor I told you about? So this is like the key, and the receptor is the lock. Okay, so it binds to it. And then you have a cage right here. And inside this cage is something called gallium-68, which is nothing but a light bulb. That's what it is. And I can take beautiful, beautiful pictures, like much better than the scan I just showed you, right? So here you go. Here's an example. This was a 48-year-old school teacher from Philadelphia. He had this mass here. Obviously he had pancreatic neuroendocrine. He had this mass here. They were thinking about doing a third operation in him, and a lot of confusion. No one knew what was going on. So he comes to see me. I'm this new kid. And he says, look, no one knows what's going on. Can you help me? I said, sure. Why don't we try this gallium scan? And this is what he actually had, right? So you don't have to be a radiologist to see the difference. And so he had a lot of lesions, a lot of tumors. So he did not need more surgery. He got something completely different. But you can see how having the right technology can significantly change what you do, okay? And when we published this a couple of years ago, we found that up to 36% of the people had some change in the way we approached it. A lot of it was actually using different kinds of treatments. We found a lot more disease. It was a little heartbreaking maybe when we first started, but I felt it was better for me to understand the true nature of the disease than to go off of bad information. Right? That kind of makes sense. So before surgery, you want to have a good evaluation, which means you should have a good office visit, hopefully with a neuroendocrine specialist, just at least once. Have some tissue pathology just to know what kind of cancer you have the right lab markers from your blood, get a good CT of the abdomen, pelvis, and chest maybe, get a good MRI of the liver to find out if there are any lesions, and a good gallium dotatate scan. Those are the things you minimally need. Because we have to figure out what's going on. I put this slide here for pathology, so just very quickly, so you can understand how the diseases are different. Some diseases, like I told you, can be very slow. We call those grade 1, so it's kind of the good, the bad, and the ugly. Okay? And there's some more aggressive ones, which are grade 2, and then there's grade 3, which is much more aggressive, and we treat them very differently. So the pathology is extremely critical. Okay. So the next question becomes, well, how do we treat it, right? And so that's, what do you do? I found this. This is terrifying. I'm glad I don't have adenocarcinoma, but what do I do now? Well, it turns out, despite we have a kind of a relatively unusual cancer, we can do a lot of things for you. There are a bunch of therapies. We can do surgery, and I'll show you some pictures of that in a second. We can give you this suppressive hormone. Remember that lock and key system? Well, we can do that and help to get the tumors to be nice and quiet. We can block the hormones in case they're torturing you. We can give these new small medications which can block magical pathways that slow it down. There's always good old chemotherapy that works in the right situation. You can actually do something called an embolization and block off the blood supply to a lot of the liver, for example, to help treat it. And there's this new stuff called PRRT, or peptide receptor radionuclide therapy, which is essentially liquid radiation from the inside out. I'll show you in a second. Okay, so this is promising. There are actually a bunch of things that we can do. All right, let's talk about surgery first. And just to warn you, I'm going to show some gross pictures, so if you just ate, you may want to just close your eyes for a second. But if you're going to talk about surgery, okay, and sometimes it's right and sometimes it's not the right thing to do, depends. That's why you want to have a good evaluation. But the goals of surgery are usually to figure out what's going on sometimes. Maybe you can cure. It's kind of a four-letter word in our field, but, maybe. Preventing complications, which is a big deal. Symptom control, because if it secretes a lot of hormone, it can torture you. And as best I can, if I can completely resect or remove that disease, that would be great. But sometimes if I can just kind of get the bulk of it out, just kind of clean it up a little bit, patients can do quite well as well, okay? So it's our job as a team, as a patient, as a caregiver, as the physician, it's the way, that risk and the benefit, right? So I want to make sure if I'm going to really do this and maybe put your life at risk, I want to make sure there's some benefit for you on the other side. The problem is the benefits of surgery are a little bit less clear. They're more clear for the lung. They're a little bit more clear for the bowel and stuff like that. But for the pancreas, it's not so clear. Some people say it helps. Some people say it doesn't. And people have been studying this for a long time. And I think it depends on patient selection, right? So this is where judgment and experience come in. And one of my mentors, a great physician named Larry Coles, he said, aggressive surgical resection for neuroendocrine tumors, the pancreas, can be performed safely and may improve symptom and overall survival, but you have to just think about it very carefully. And you may even be able to do it when people have metastases, okay? So there's a lot of thought to it, all right? So let me show you why. All right, so, okay, this is it. This is your warning slide, gross surgery and squishy organs. This is what I do for a living, so avert your eyes if you can't take it. Okay, this is what a pancreas generally looks like. It's like this banana-shaped yellow organ. It is magical. It's an amazing organ. I've been working with this thing for, feels like my whole life, and it is, I cannot even begin to tell you how astounding and how difficult it is to work with. But this is what it is. And you see it's normal, has these little lobules to it. It's relatively thin. It's not super impressive. But neuroendocrine can really cause a problem. Look here. You see this gigantic tumor that's coming off of it? Look how purple it is. The reason it's purple is because it has a lot of very rich blood supply, right? Because it's a hormone tumor. So it needs the blood supply to secrete the hormones, right? And then here's the rest of the pancreas right here. This is the rest of the pancreas. So it can look like that. It can look like this. This whole thing is one big old pancreatic neuroendocrine tumor. See how it dimples in like this? It actually kind of pulls and scars things in. This is the spleen back here. And so you can see it's a complicated tumor, right? And, I do this every day, and so sometimes I'm like, this is a crazy disease. Why? Look at it on the inside, okay? I know it's a little gross. I apologize. But this is the tumor cut from the inside. Look how it has this like white kind of creamy color to it. And that's because it's an endocrine, like I told you, it secretes a lot of hormones. And so it needs a lot of fat, almost like a waxy kind of a color to it. And look how almost like there's no pancreas left over because it's all been replaced by tumor. And here's one that I removed just a couple of weeks ago. And look, this is all tumor, okay? So it can grow. It can grow aggressively. It can cause a lot of problems. It can secrete things and can not secrete things. And so we try our best to get them out in the right situation. Why? The thing I worry about is something called splenic vein thrombosis. So here's a picture of the pancreas here. These little purple things here are as you can see, the purple things are the veins that drain the spleen and the pancreas and the bowel. But if you get a big fat tumor right there, it blocks the blood flow. So it's like having varicose veins. And, And then what happens is, didn't work. Okay. Anyways, these veins start to grow out. And so what happens is you will get varicose veins of the gut, which is not pleasant and unfortunately can be very dangerous. Let me show you an example. This is a CAT scan. I know it's a little hard to kind of see, but this is a CAT scan, and the tumor's here, the tumor's here, the vein is blocked, and this is a gigantic spleen right here. But if you look right here, see these scraggly things? Those are all those little veins that have kind of gotten all junked up. It's like, whatever major highway you live by. Imagine when there's an accident and all the local roads get filled up. That's what that is. And this is what it looks like. This is a normal vein. See how nice and small it is? This is a congested vein, and that's not how it's supposed to be. And what will happen is these will bleed, right? And so we can get what's called a GI or a digestive bleed, and it can be life-threatening. So we have to watch out for that. Excuse me, let me just blow my nose. I apologize. I was on a plane. I think I caught something on the plane, so at least we're not together. So you can see there, that's something I really worry about because that can be life-threatening. It might require transfusions and things like that. But some of them are small, and you can see here this little doodad thing right here in the middle. That's the neuroendocrine tumor. And you can see it has that kind of that waxy color to it, very classic. And sometimes they can just be a little bump, right? So here's an example of a 70-year-old lady had a chest CAT scan for a breathing issue. they found this teeny tiny little thing on it very astutely, right there, boom, that little white thing. And everyone said, you have to have surgery, you have to have surgery, surgery, right? I said, look, hold on a second, ma'am. I don't think you need to have surgery. She said, well, everyone tells me I need surgery. I said, well, let me show you. So we followed it, and there it is here, right there. And there it is here, and there it is here, and there it is here. And now she's 74 years old, so I didn't have to do anything, and she's perfectly fine. And I spared her having to remove the distal part of her stomach, the first part of her small intestine, and the head of her pancreas. Right? So that's the thing. And it turns out it's not just me. Sometimes these things are just growth. And a nice group from Oklahoma and Stanford did an analysis of a database, and they found that for these small lesions, you can just kind of watch them. In fact, you can maybe even watch them up to 2 centimeters. So there's a lot to think about. So you can see there's a lot of nuance to the disease. Okay. Now, when it comes to doing surgery for the pancreas, you have to be careful. You have to do very good critical imaging because you might have a little thing that we can just kind of pop out. You might need a portion of the pancreas removed, like maybe the whole back of the pancreas removed like this. Sometimes you need to have the whole head of the pancreas removed, which is a very, very big, difficult operation. And in some terrible cases, you need the whole pancreas removed. That's unusual. But again, there's a lot of thought to it, right? So don't jump into it. The pancreas is hard enough, but it spreads very quickly, and it can go to the liver, right? And so sometimes we need to go and get these things out, and I can go into the liver and remove a lot of these tumors, see, in here, and that helps in certain cases. But sometimes you can go to other places too. There's a lady who had it. These used to be ovaries. This thing here and this thing here used to be an ovary. This used to be a uterus. And you can see this is not normal. All of the tumor went to these 2 locations. So that's what we have to watch out for. So removing organs that help the person, and the reason we took them out is because she had pelvic pain, right? So if I'm going to keep her alive for many years and she continues to have pelvic pain every single day, I don't want to do that. So I want to help her. So this is why we did that. Now that's surgery, but there are actually a lot of really neat medicines we have for tumor control. The one that we really work on is something called the somatostatin analogs. Remember the lock and key I told you about? Well, one of the keys is just a medicine version of it with no light bulb behind it, and you can just treat people, and it works quite well. Here's the classic one. This one is called sandostatin or octreotide. We've been using that for 30 years. We have another medicine called somatuline or lanreotide, and they've all been demonstrated to help improve and slow down the growth of neuroendocrine. It's not magical, okay, but they work pretty well, especially with very slow-growing disease. So you can see here, these are some graphs, but everything on the down is worse, everything on the up is better, and you can see people who got treated did better here. People who got treated did better here. So those are our 2 hormone shots. But there's a medicine called sunitinib, which is a pill that you take. It's called a tyrosine kinase inhibitor. People who took that did better. There's another medicine called everolimus. People who took that did better. And so we have actually quite a few medicines. The challenge is that they've never been proven to make people live longer, but they can definitely slow down the growth of the tumor. So it's still an important tool. Now, there was a really nice study done over the past couple of years looking at pancreas neuroendocrine and something called CAP-TEM, or capecitabine temozolomide. It's a combination of 2 medicines you can take by mouth, but they're chemotherapeutic drugs. And Dr. Coons found, and her colleagues found, that if you took the drugs together, you had a better survival. You can see that better survival here than if you took just one of them alone. So this is a really nice combination. In fact, a third to maybe a half of them actually have shrinkage of the tumor, so it's a wonderful tool to have. And in some cases, chemotherapy is still the way to go. If you have very, very aggressive disease, chemotherapy is still the right treatment. Sometimes all the disease is in the liver, and so if we can treat the liver, then you can spare a lot of the rest of the body. That might be a way to go too. So the interventional radiologist can shoot beads inside there. They can shoot chemo into your liver. They can even shoot radiation into your liver. So all these things might be options for treatment and getting your disease under control. Because remember, with neuroendocrine, every day you're under control is a day you're alive. And if we can keep it under control for many, many years, people can live with disease for many, many, many years. So the philosophy is more of a marathon than a sprint. The analogy I like to give is it's a little bit like, so if you have pancreatic adenocarcinoma, right, you are like driving on the edge of a snowy mountain. Okay, I live in Colorado, so we do this. So the edge of a snowy mountain in a small road. If you fall off, that's it, you're done. Neuroendocrine is a little bit different. It's like driving through a 12-lane superhighway. My goal is to keep you going straight, but if you veer a little bit to the side, it's not terrible. It's more tolerant. The problem is if you keep going to the side, you can fall off a cliff too. So it's always trying to keep you going straight. Does that make sense? So it's a little bit of a difference in philosophy. Now, so we've talked about surgery. We've talked about medicines. We've talked about embolization. And those are kind of the classic things that we do for neuroendocrine. But I told you a little bit about that radiation and some of the nuclear things that we're doing. It turns out that we can actually do the same thing as a therapy, okay? And it's called peptide receptor radionuclide therapy. Let me show you. So remember when I showed you the lock and key, right? So here's the lock, here's the key. It turns out instead of not just putting a light bulb on the back of it, you can put a nuclear bomb on the back of it. So it's like a guided missile with a nuclear bomb. And then what happens is the nuclear bomb goes into the cells, the cancer cells, and they can irradiate the tumors from the inside out. It's called peptide receptor radionuclide therapy. Okay, fancy. The trade name is called Ludecera. That's the name of the drug itself. But this is how it works. It's been around for like 20 years in Europe, and we've just gotten it recently. But this is how it works. Basically, the nuclear bomb comes along, attaches its guided missile. Okay, it binds to the locks on the cell, and it's absorbed. So you actually get radiation from the inside out, okay, rather than the outside in, and it targets just the tumors. So here's an example. This is a very dramatic one from my friend in Sweden. But she had this one patient who was just dying of his pancreatic neuroendocrine tumor. He was in hospice. He was 40-some-odd years old. It was over. So they gave him this treatment, and it went away. It was actually quite dramatic. And this does happen sometimes. I can't tell you why, can't tell you who, but it was dramatic. He did eventually succumb to his disease, but it was amazing. So there's a lot of interesting hope for it, or exciting hope for it. Now, this trial, just so you know, was done in a big trial of patients with small intestinal neuroendocrine, so not specifically in pancreas. But you can see, remember, down is worse and up is better. And look how much better. You can drive a Mack truck through the differences between these two curves, okay? So it shows you how effective it is. And in differences, what they found is that if you got the therapy, people actually lived longer. They actually lived longer. And so that's always our goal. So this is kind of how it works. Sorry, the movies don't work very well, but basically the medicine goes in. The water, the saline goes in one side. It comes out with the radiation. It goes right into your arm. It's not fancy. It's not sexy, but it works, right? And so there was a nice review done by our colleagues, and what they found is specifically this PRRT treatment for pancreatic neuroendocrine tumors favors its use as a modality for pancreatic neuroendocrine. And just understand, remember that big phase 3 trial was just in small bowel, and that's for regulatory reasons and stuff like that. But it is approved for pancreas as well, too. In my experience, it's not quite as robust. It works quite well. Don't get me wrong, it works quite well. It's just not quite as long as for the small intestine, but it's still an excellent, excellent treatment. Excellent treatment. All right. So let's talk a little about research. We've talked about, how to diagnose it, how to test for it, how to do scans, how to treat it. But there's all kinds of interesting things that are coming out soon, right? Everyone's talking about immunotherapy in cancer, right? So the immunotherapy may not be so awesome for neuroendocrine, okay? Maybe very aggressive neuroendocrine. But you can see here the rates of control are relatively low for neuroendocrine immunotherapy. Here's another one, too, looking at this blockbuster drug called pembrolizumab, and it didn't work so well for neuroendocrine. You can see kind of people fall off the curve, a little bit like that other curve, and people don't live so long. So it's not perfect. I think there's a lot of potential, but it's not perfect yet. Here's another one looking at 2 immunotherapies in neuroendocrine. And again, you can see the numbers are a little bit on the low side. So most of the disease was stable, which is great, but a lot of people still kind of progressed. Right? So it's not perfect, but we'll figure it out. Now, the good thing is there are a lot of ongoing clinical trials all around the world, which is actually very exciting. People are looking at combination therapies here. People are looking at sequencing. People are looking at reusing old medicines, maybe in combination with other medicines. So that's pretty exciting. And there are a couple of new medicines. I won't go into the details, but just for example, there's this new drug called surufatinib that's being tested in pancreatic neuroendocrine tumors. And hopefully that will be yet another tool. It will probably take a couple of years for it to kind of really be robust and mature. But there's another big trial going on looking at this medicine called cabozantinib. And cabozantinib is a kind of a sister drug to that drug sunitinib. And so maybe that will be more effective or maybe better tolerated. So we'll see. So the one thing I do want to say is that over the past 10 years that I've been in this business, I have seen people become more interested in neuroendocrine, more interested in researching this unusual rare disease. It's not so rare, but it's unusual disease. And so I think there's a lot of potential. So I think it's very, very exciting that more people are getting into this field. And actually one thing I'm really excited by is people are looking at combination therapy. So this is actually a chart, slide I got from Dr. Del Rivero at the NIH in Bethesda, and she's doing this really interesting study looking at that PRRT treatment with some of the classical it's not a chemotherapy drug, but it's like the oncology drugs that they use called a PARP inhibitor. And she's hoping that the combination of the two will make it even better. And this trial just opened a few months ago, so there's all kinds of exciting things that are happening. So I'm very encouraged. Now, there's actually something else that's happening, too, which is not quite ready for neuroendocrine, the pancreas. But it turns out those shots that we were talking about, those hormones like octreotide and lanreotide, well, there might be a new version that's coming out in pill form. Again, very, very preliminary. They're looking at a different disease called acromegaly, which is a different kind of a neuroendocrine disease. And so that's what they're looking at. But hopefully maybe this pill someday they'll study it in neuroendocrine. Okay? So I'm excited by some of the things that are coming through, and we'll see. It'll take time. It'll take time, and we have to be patient. We've seen lots of things tested that don't work at all, and we've seen some things that tested that work great. So we just have to be very cautious about how we approach these things. Okay? So hopefully that leaves us with a little bit of hope for things that are happening. So let me just tell you a little bit about how I think of neuroendocrine as a specialist. This is the deal, okay? The art of neuroendocrine is not what to do. It's when to do it, okay? And that's really the thing. And that's why there's so much judgment, experience, and things that I like to think about when it comes to neuroendocrine. I mean, I do this every day, so maybe I'm overanalyzing it. I have no idea. But I know for sure that every zebra that walks in the door is different from the zebra that walks out of the door. Why do I say that? If you look at the guidelines, this is a very, very important document that comes out of something called the NCCN, which is the big conglomerate of universities and super experts in these fields. But if you look at it, they say, do this, do this, do this, do this. But the problem is you can do this or this or this or this or this or this. The problem is it doesn't tell you what to do for Mr. Jones or Mrs. Smith who's sitting right across from the table from you. And if every person is different, then which tool do you pull out of the toolbox? When do you pull it out? Again, it's like those old Westerns. You don't want to fire all 6 of your bullets off at the very top or at the very front, or you'll have nothing to use at the very end. So it does take a fair amount of thought. It does take a fair amount of experience. And so I always encourage people to at least have a neuroendocrine expert as part of the team. You don't have to see them every day. You don't have to see them every month. But just checking every now and then to make sure you're on the right course, just so you're going straight. I hope that makes sense. So basically this is how it is. Each individual is different, right? You can see their stripes are different, their things are different. And all I hope I can do is lead all of you zebras to the water so you guys can do well and flourish. All right? That's it. That's all I have. Thank you very much. I'm very blessed and honored to work with a lot of really great people in our community, and there are a lot of great docs, and actually very encouraging. There are a lot of new, younger doctors who are getting to the field. So hopefully as the awareness of neuroendocrine goes up, and I think people like PanCAN who, despite the fact they specialize in adenocarcinoma, are actually very involved in understanding and spreading awareness for neuroendocrine too. But there's a lot to be done, and there are a lot of people to be helped. So I hope this was a helpful session for you all. Thank you very much.
Thank you, Dr. Liu, for a very informative presentation. At this time, we do have time for questions. So I will go ahead and start with the first one, which is, can one differentiate between a pancreatic neuroendocrine tumor or other type of tumor, such as adenocarcinoma, on an imaging scan, or is it necessary to do a biopsy?
Well, it's tricky. That's a really important question because, like I told you, you have to differentiate between the two. So the answer is yes, possibly. So if someone looks at, a good radiologist looks at it, they can sometimes give you a suspicion as to which one it's going towards, but that's not definitive. If you get a gallium scan, that's actually pretty definitive, and it's positive. The gallium dotatate net spot scan is positive for neuroendocrine. It's probably going to be neuroendocrine. But essentially, no oncologist will treat you unless they have a tissue diagnosis, and so most everyone needs a biopsy anyway. So that's kind of how we do it.
Great, thank you. The next question is, are there any recent updates on new or effective treatments for advanced high-grade undifferentiated neuroendocrine tumors involving the pancreas?
Yeah, that's hard. So unfortunately, the high-grade undifferentiated is the ugly version. They are aggressive cancers, very aggressive cancers. And they are difficult. We had been working on the community had been working on this immunotherapy, which may or may not have a perfect role for it. Chemo is still the backbone. There are some research studies going on looking at other types of immunotherapy for it, and maybe in combination with chemo that may be more helpful. But unfortunately, high-grade neuroendocrine carcinoma doesn't have a doesn't have a big voice, and so there's not a lot of research being done on it. So it's a challenging disease.
Thank you. The next question is, what do you recommend for patients who are not close to a NET specialist? Would a remote second opinion be a good choice?
Oh, that's an interesting question. I don't know the answer to that question. I'll tell you from my experience. So a lot of people fly to Denver to have their care done, and I know it's difficult and expensive to come, and so I respect that. The issue is a remote consult, which I tried to do in the past, is never complete. I know it sounds crazy, but despite all our technology and webinars, if you don't sit here with me, I never can quite put all the pieces together. And, because despite the fact we live in the 21st century, most of the records and documents I get come through fax, right? And it depends. Does your hospital send me the right thing? They send me 75 pages of old chest x-rays but not send me the right report. So it can be very challenging. So I say if you can get in a car, there's usually someone, and I know this is not perfect, there's usually someone within about 4 to 6 hours of a drive. So I think it's usually worth it for at least one visit so they can at least kind of piece things together and figure things out, and then work with the person back home. So it's a team effort.
Definitely. Thank you for that. The next question is, where can one access a 68 gallium dotatate exam?
Well, actually, thankfully, the gallium-68 dotatate scan is much, much more widely available. And it's available, as far as I know, in almost every major city. You would have to call, the company is called Advanced Accelerator Applications. I'm sure if you looked it up, you could figure it out. And then they can tell you where all the, what are called generators, they can tell you where they can produce it. And then you can go there and get it done. And so your doctor, it's not that complicated. The doctor can write a prescription and then send it to the hospital or wherever, and it can be done. You might have to go through the company to ask them, what's the closest place. But I think pretty much every major city has one.
Oh, perfect. Thank you for that answer. The next questions are related to surgery. So when is surgery an option for patients with PNETs, and is treatment after surgery necessary in these patients?
Well, that's a complicated question. So the answer is yes, of course, right? And so people need these things. Surgery is not perfect, right? Obviously, there are risks to the operation itself, But the truth of the matter is I can get a lot of stuff out, get things cleaned up, and be very happy with it, but the disease usually comes back. And it's not that it comes back. It's that it was always there, and it was either very small or microscopic, or sometimes they can't get it all out. It's not easy. A lot of the time when I can, quote-unquote, cure people of the disease, it's because the disease was so indolent to begin with, it probably didn't need curing. So who knows? That's a little bit, there's some debate there. But if we can do the surgery safely and remove it, usually the patients do quite well. The problem is in the future, when it sprouts its ugly head again, then you need some treatment. Now, if it sprouts itself up in 6 or 7 years, great. That means you have very slow disease. We can treat it, we can keep an eye on it, and keep things going. So there's a very high probability that anyone who has a disease now gets their surgery will see it again in the future. And this is all about kind of managing it and kind of keeping it under control so it doesn't hurt you and affect you too much. Because people can live with neuroendocrine.
Thank you for that answer. The next question is related to profiling. Do you recommend molecular profiling for neuroendocrine tumors?
Now, that's very interesting. So just so you understand, what molecular profile means is you take the little specimen that was from surgery or from your biopsy. They can do magical scientific things to it and extract the DNA inside of it and sequence it and look at it to see what kind of mutations and what's going on and why it's different. I personally don't love genetic sequencing and tumor profiling because I'm not sure it has a huge impact. There was a day in which we thought genetic profiling was going to cure cancer, right? You could find the mutation, you could give it the right treatment, and that would be that hasn't quite worked out. I mean, it's very promising, don't get me wrong, it's an important thing to do, but it's not perfect. And so it's a tool with everything. It's just a tool. With neuroendocrine, we have found certain mutations which, how do I say this? We've found certain mutations which unfortunately don't really change the way that we treat the patient. So the actual profiling may give you a sense of how aggressive it is. It may give you a sense of what the mutations are. It may give you a sense of what clinical trials you would qualify for. And that's all important information. But the actual value is not as high as I had hoped it would be. I'm not saying don't do it. I'm just saying that the result may be more limited than we had hoped. So just be aware of that. So until we have some major breakthrough, for example, the gallium scan, if you get a positive gallium scan, you are a candidate for PRRT. They go hand in hand. They are locked together like this. So that's very important to do. But if you get a genetic sequencing, and I'm not always exactly sure which medicine to pair up with it, so it's not always perfect. Sorry, it was a long, convoluted answer to a difficult question.
No, that's a great answer. Thank you. Kind of going back to the topic of surgery, we have a question related to after removal, is there ever a time that you can stop follow-up? If so, maybe about how many years?
Well, that's actually a very hard question to answer. So in general cancers, just not neuroendocrine, but other cancers, 5 years is usually considered you're cured. I use that term loosely, as you can tell. But neuroendocrine is never like that. So I tell people, and this is just what I do, okay, so people, you'll hear different things, but what I do is I have seen people recur like 15 years later. Right? I have one lady I take care of, hers is lungs, a little bit different. She had an operation at 18. She was told she was cured. She's now 48 years old, and it's all over her bones. And she's fine. She's fine, and we still take care of her, and she's doing great. So having seen all these things, I always tell people, look, you can divorce your spouse, but you can't leave me. And so we have a long relationship, and so I follow people for a long time. So I cannot give you a great answer. Usually I feel better after 5 years, but you never know. So we always just kind of spot check every now and then.
Thank you. The next question is, how do you determine if a patient is a candidate for PRRT or not?
Well, again, so you don't want to shoot your bullets up before it's too, you want to do it just the right time. So the first thing is to know if you're a candidate. And to know if you're a candidate, you have a bright gallium dotatate scan. What does that mean? If you look at the report, okay, a good report, and not every report is good, okay, let's be very clear. Not every report is good. But if you look at the report, it should describe to you how intense the uptake is. There's a value called SUV. It's not sports utility vehicle. It's standardized uptake value. If that value is high, like above 10, 20, 30, 70, 100, then you're a good candidate for PRRT. But that doesn't necessarily mean you need it. Okay? If you have two teeny tiny little tumors, you don't want to shoot everything off at that time. You may want to wait 5, 10, 15 years before you actually do the treatment. Again, very important to consult with someone who has experience with this disease.
Great. Along the same sort of route, does radiation from PRRT impact surrounding organs or tissues? If so, to what extent, and how does this compare to conventional radiation?
Now, that's actually a very, very important, good question. Liquid radiation therapy is completely different from what we call external beam radiation therapy. External beam, you shine the radiation from the outside in, so it hits everything that it travels through. Now, the radiation oncologists are very, very good at this, very good. They can adjust the doses, the machines, the computers. I mean, it's really impressive. But you still burn things. So, for example, if you wanted to treat your pancreas, you'd have to burn through the stomach, and that can cause problems. You'd have to burn through the skin. We still see that. This liquid radiation, or the PRRT treatment, is a little bit different. It goes through your veins. It goes right to the tumor. It's absorbed by the tumor. Now, there are side effects, right? If it's a real therapy, it's going to have real side effects. And the major side effects is that some of the radiation can leak off and go into your bone marrow, and it can suppress your bone marrow. Usually it comes back. That's why we space the treatment every 8 weeks, so it can go down and then come back. So the counts can go down and come back. Some people, unfortunately, the counts go down, they stay down forever. And there are some people, very, very, very rarely, who can develop actually cancers of the bone marrow, so like a leukemia. So they're rare, but they do happen. It's a very safe treatment. But as far as affecting other organs, it's really quite good. The penetration and the width of the treatment is only about 1 millimeter. So you get this 1 millimeter tiny little ring around your treatment, and that's about it. So most people get a little fatigue, and I don't want to overgeneralize it, but most of the time people get a little fatigue, they get a little suppression of their bone marrow markers, and then they do pretty well. So it's a very well-tolerated treatment, despite the fact it's sounding nuclear and radioactive and things like that. Actually, it's quite well-tolerated.
Thank you, Doctor. And we have one more question. So can a tumor change from low grade to high grade?
Oh, I hear this question a lot, and I don't know the answer. This is complicated. Let me tell you why it's complicated. So, I think of tumors, well, this is how I do it. When I think of a person, I told you each person is different from every other person, but when I think of each individual person, each of the tumors is different. So some may grow, some may be very dormant, some may secrete things, and so I think of each of the tumors within the individual differently. They're like, I hate to say this, but they're like children, right? So you can have poorly behaved children and you can have well-behaved children, and the same thing happens with neuroendocrine. And so we did this study many years ago where we said, well, why don't you cut into every single tumor and just find out how they behave? Some of them were uniform right across the line, very quiet and very well-behaved. And some varied. Some were very well-behaved and some were terribly behaved. Because if you think about it, why are some tumors this big and some are certain tumors this big and some tumors are this big? So I don't really know. Like maybe this tumor was always a grade 3 and this tumor was a grade 1, but they biopsy this one and so you don't always know. So the only test that absolutely works for this is the test of time. So you can track it over time to see how it is. Now the one thing I will add is that I have seen people be relatively dormant and then something happens and the disease does change. So I don't know if the treatment we gave kind of keeps all the well-behaved stuff under control and then some tiny little element of poorly behaved changes over time. So it's possible. I've definitely seen it before. But there are a lot of nuances to it. It's not the rule, but it does happen. So we do have to keep track of these things.
Thank you, Doctor. At this time, we would like to thank Dr. Liu for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would also like to thank our webinar sponsor, Ispen, and our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ispen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. A survey will pop up once you leave the session today. Please take a moment to share your feedback. If you have any questions, including finding a pancreatic neuroendocrine specialist in your area, please contact Patient Central at 877-2-PANCAN and ask to speak with an associate. This concludes the webinar. Thank you.
Bye, everyone. Have a good holiday.